My name is Vasu Rastogi. Would like to welcome all the respective faculty member and participant for this scientific symposium on heart failure management. As all of us are aware about that heart failure is one of the increasing burden to our society, and most of the patient could not able to live their life fullest. So as there is one famous saying that you take care of your heart and heart will take care of your future and body. So to discuss about this important aspect, we have eminent faculty from the across the India, and we have the today's moderator, Dr. Rajeeve Rajput, who is a senior cardiologist based at Apollo, Delhi, and he is having a experience of more than 20 years and having a special interest in the management of heart failure. So to carry forward this session, I would like to invite Dr. Rajeev Rajput. Dr. Rajeev, over to you, sir.
Thank you, Vasu. Thank you very much. On behalf of Apollo Hospital, Healthy Heart Foundation, and Novartis, I welcome you all for this webinar on current trends in management of heart failure. We have designed in such a way because it's a vast subject to keep focus on just the recent developments which have taken place in last few years. It is my proud privilege to have our Director Medical Services, Dr. Subramanian, and it was so kind of him to agree despite this, his busy schedule and COVID times and a lot of things going on in hospital. Thank you very much, sir. And I would request him to say a few lines and declare this webinar open.
Namaste. Thank you, Dr. Rajput, and I think the organizers of this wonderful event. I think we all realized that while we were fighting the COVID deaths, the number of people who die from cardiac conditions is still far, far higher. So I think we need to retain focus on that. Heart failure, as we all know, is a very common and a serious cardiac condition which affects millions of Indians. It's associated with a high mortality, frequent hospitalization, and a poor quality of life. Rheumatic heart disease, hypertension, coronary artery disease have been amongst the common causes. Over the last few decades, there have been significant developments in the field of diagnosis and management of heart failure, including the use of biomarkers, the use of better drugs and devices. Mechanical assist devices and cardiac transplant are very rewarding in the established centers and are great options for people with end-stage heart failure. It is, however, very disturbing that most of the patients in our country do not get the desired treatment, and there is considerable scope for improvement in this field. Some of us would feel that focused heart failure clinics can be a very helpful step in this direction. I am very sure that this webinar, which I could hear has a very wide range of accomplished speakers from various esteemed institutions, will enlighten all of us about the recent developments in the field of heart failure, help us into a lot of interactive discussion on what is the best for the future. So I am very, very pleased, honored, and delighted to declare this webinar open and wish all of us excellent deliberations for this evening. Rajeev, I must thank you, and Mukesh, welcome. And I think all the wonderful speakers, Professor Bansal, Dr. Modi, and the galaxy of great speakers will definitely enlighten all of us. So let's all have a wonderful and productive evening, and let's defeat heart failure. Thank you.
Thank you. Very well said. Thank you very much.
Thank you.
So with these kind words, let me just get the ball rolling. Yeah. Yeah. As our DMS pointed out, heart failure is very common. It kills millions of people, leads frequent hospitalization, poor quality of life, And despite proven therapies, the utilization of these proven therapies is not optimal, or I would say far from optimal. The transplantation and assist devices, etc., are established treatment in the West for many decades, and they are just picking up in our country. There are various reasons for why we are not able to utilize these therapies, which we will discuss. Another disturbing feature is that since our longevity is increasing due to better health care, and I would say better treatment of common heart conditions, heart failure, since it is very common in aging population, the prevalence is increasing. Unfortunately, if you look at the outcome of heart failure across the globe, we are only better than Africa. And as compared to the developed countries, our outcomes in hospital and outside hospital are not as good, or in fact very poor. There are various reasons to that. And at this slide I have collected to just highlight the discrepancies. In US, we do around 2,200 transplants a year. In India, so far there is a rough calculation of 1,200 transplants in total. Assist devices 9,000 per year. So far, the data from the company says 25 devices. AICD more than 100,000, 1,200 in India. Resynchronization therapies 41,000, less than 700 in India. I know cost is a factor. There are other obvious reasons, but having said that, there is a lot of scope to improve. The classification of heart failure has changed a bit. I'll not go into this. There are not 2 but 3 types of heart failure: HFrEF, HFpEF, and heart failure with mid-range ejection fraction. So with this, the first part will be 2 lectures, one by Dr. Jayagopal and another by Dr. Sandeep Bansal. I must set the context. Dr. Jayagopal has been instrumental in the ICC registry of heart failure, which is probably the biggest database in India about heart failure patient, and he will share his inputs about the findings of this registry. And this will be followed by talk by Dr. Sandeep Bansal about the current medical treatment and what is new in 2000. Dr. Jayagopal is Director, HOD and Senior Intervention Cardiologist at Lakshmi Hospital, Kerala, Vice President of Indian College of Cardiology, Executive Committee Member of National Council of India, Cardiology Society of India. He is Principal Investigator and Coordinator for Heart Failure Registry. He is an editorial board of Indian Heart Journal and has been co-investigated in Kerala acute coronary syndrome. And I must admit that the most important epidemiological data from India has come up from Kerala, whether it is being ACS or heart failure in last decade, I would say. So with this background, I would invite Dr. Jayagopal to share his views. Epidemiology of heart failure in India, East or West, how are we different? Dr. Jayagopal, please.
Thank you, Dr. Rajput. Let me just share my screen.
Yeah.
Yeah, I hope it's visible. Good evening, everyone. At the outset, let me thank Dr. Rajput for having invited me to take part in this very important educational webinar. And I must say that I'm really happy to be part of a heart failure program, because this is where I have really put in some effort in the last few years. So the topic that has been given to me is heart failure in India, and I thought the question was, is the heart failure in the East, whether it's different from the West? I thought I'll focus a little more on heart failure in India, because that is where I have had some work done in the last few years. Sorry, just one second, please. There's some snag in the. I'm sorry for the.
So if the slides are not changing, please click on the screen, then it will change.
Yeah. So I think world over, whether if any part of the Western country, whether it's Canada, United Kingdom, US, or any part of the world, I think the major problem, as we all know, is the ever increasing number of heart failure, and this is indeed becoming a major problem. Close to about 2 million hospitalizations every year, and it's predicted that by 2030, 1 in every 33 will have heart failure. So this is in fact very troublesome, and in fact a very scary sort of a scenario. And then if you were to look at what we are going through right now, the pandemic which started in Wuhan, we thought it might not affect India, but then now we probably top the list. And then the question is whether the epidemic of heart failure, is it worse than corona? As was rightly said in the inaugural talk, all of us have been focusing more on the corona, but I think I must confess that the main killer these days has been heart ailments, which people are really scared to in terms of getting the appropriate medical attention. Now, the data from India is very sparse. In fact, all these are, I must confess that these are all projected burden what we have from the Western countries. And then we look into the history of myocardial infarction in the country. We know about 21 million Indians are affected. The heart failure burden due to MI is about 2.1 million to 8.4. Hypertension is becoming an ever increasing problem, close to about 34%, 35% of our population. The prevalence is as high. And so because of all this, the prevalence of heart failure in India is expected to is projected rather about 1%. But I would say this is really a gross underestimate. And the vulnerable mortality, what has been the published data from Chaturvedi, is about 0.1 to 0.16 million. So I think I must tell you that over the last few years, we have had very little data. In fact, one of the most quoted study has come from Kerala, the southernmost part of the country, Trivandrum Heart Failure Registry. But this is actually a very small population of about 1205 patients in a very small area around Trivandrum and the suburbs. And of course, we have had this CHF, which is again confined to some smaller hospitals and also the tertiary care centers. And of late, the recent Medanta registry, which is again confined to one particular hospital. So what is important is to understand that we are actually having a much younger patients. Of course, there's no doubt that ischemic heart disease is a major factor, and we find that from the Trivandrum Heart Failure Registry itself, the mortality rates are considerably high. The in-hospital mortality rates are considerably high, and 1 year mortality, which I'll discuss, is really phenomenally high in India compared to the Western population. And the other part is about the treatment. That is what we are interested in. The ACE inhibitors and the ARMs were very dismally low figure. And what you see from the Medanta registry is encouraging because the use of ACE and ARBs has increased there. But I must again tell you that this is a premium sort of a center, the tertiary care center, where the care would be vastly different from what is generally available in the general population. So I think, what did we see from Trivandrum Heart Failure Registry? The mortality rates at 1 year was close to about 30%. 1/3 of the patients were dying at the end of 1 year, which is a very scary sort of a figure. And most of the deaths occurred within the first 3 months, and mostly so in patients less than 70 years of age. And they also found that increasing age, past history of a vascular event, higher renal parameters, higher in serum creatinine, and more important than that, suboptimal guideline-based medical therapy or frequent hospitalization were the major causative factors. But actually, this is data which has come sometime ago. So if you were to look at the INTER-CHF, which is the most often quoted work all over the world, what is mentioned here is the patients from India were younger, had little education, more symptomatic, lower rates of coverage in terms of health insurance, more from a rural area, and more often treated with digoxin. And today we all know that digoxin is nowhere prescribed as a guideline-based medical therapy. So there is a lot to be said about what we are doing right now. And what is even more scary, what actually came in the internet news, is that the mortality in India is close to about 23%, vis-a-vis 7% in China. So that is something which we need to really understand from this INTER-CHF registry. So the question is, are we really underdiagnosing heart failure or missing it? Are the demographics and etiology different in our country? Treatment pattern, is it suboptimal, same, or different? So I think it is with this thought that we started we mooted the idea of starting a registry to collect the data from across the country And that is what the pilot study, which came in the year 2018 and went on for a year up to 2019 August. And we started this from the southern part of the country and then went over all over the, there were only a few representative cases from centers from the north and the east. And then it was actually an ECRF format. And so we had a training program and the data was collected. And someone is really interested, the rational methodology and design of the Indian College of Heart Failure Registry, which is now a CTRA approved one, is available it is published in the Journal of Indian College of Cardiology. So the initially, after a few months, we actually looked at what we were heading for, and this was an interim analysis which was presented in the European Heart Failure meeting in 2019 in Athens. And what was seen there is the fact is that majority of our patients were younger, and then close to about 50% of the patients were diabetics and hypertensives, and also the fact that ischemic heart disease constituted the majority of patients with heart failure. And also acute decompensation heart failure was predominantly with a reduced ejection fraction. So these were the things which came out. We have completed 1 year. I cannot fully, this is all unpublished data. In fact, this is just going in for publication. So we studied about 5,269 patients, and it's close to about 70%, less than around 70% were patients with a low ejection fraction. And what we found was the in-hospital mortality was close to about 6.3%, not really bad as what we thought once upon a time. But the post-discharge mortality at 30 days was another 4.8%. Rehospitalization 30 days was 6.2%. And 1 year mortality, which we have just compiled, is close to about 20.6 mortality. So this is not like the 30% mortality which was talked about in the random heart failure registry. We also looked at the risk factors. As mentioned earlier, ischemic heart disease contributed about 62%, hypertension, diabetes about 50%. And what is more important is chronic kidney disease is constitutes 15% of the admission. And rheumatic heart disease has become very small number right now, only about 4.2%. And interestingly, we also see that the average hospital stay was only about 5.7 days in the whole 5,269 patients. We also know from the data in the Western countries, all these heart failure patients, acute decompensed heart failure patients, whether it's a 30-day, whether it's a 1 year, whether it's from US, Europe, or anywhere in the world, close to about 30% of the patients get admitted with again an event. And if you were to look at the 5-year outcomes, which is Journal of Cardiology, you find that whether it's a reduced ejection fraction, mid-range, or a preserved ejection fraction, at the end of 5 years, close to about 97% of the patients, either they die or they get readmitted. So the long-term prognosis is poor, and this is what is available from the Western literature. So, but I think it's what is probably more, little interesting to note is that we started with the Trivandrum heart failure registry long ago, 30.8. What we saw in the Medanta was about 17.3% mortality, and what we have found from the National Heart Failure Registry across the country is close to about 20% 1 year mortality, which is something probably, I would feel that the mortality rates are now coming down with better treatment. I think it's very clear that the survival rate, what is to either 20 or 30%, is much worse than either a prostatic cancer in the male or a breast cancer in the female. So I think it's very important for physicians to recognize this and treat them appropriately. More important than that, when we started looking at the mortality, it's very clear those patients who had a suboptimal therapy had a higher mortality than patients who had a guideline-directed therapy. And not only that, if patients were on at least 3 guideline-based therapy, all 3, the mortality rates were much less compared to those with 2 and 1 drug alone. So I think the significant higher mortality in patients who did not receive guideline-directed medical therapy, which is very important. So the question why we started this registry is to address this issue. And if you were to look at the registries from the Western country, the AIIMS, optimized heart failure and all that, you find that the ACE inhibitors is close to about 40 to 40% in these. The aldosterone antagonist is dismally low. It's about 50%.
Hi, Dr. Pandey, how are you?
And if you were to look at
आपके कैमरे पे कुछ साइड में आ रहा है, शायद कुछ उस पे देखिए कैमरा किधर है?
some noise.
Therapeutic
approaches, you find that from our the heart failure registry itself, 30% of the patients are ACE inhibitors.
अच्छा, इधर कोविड नहीं होगा हम सबको.
50% of the patients are on beta blockers. But use of aldosterone antagonist is close to about 1/3. And what is more important, the new kid in the block, the ARNI percentage was about 3.3% at the admission and 2.3% at discharge. But I think I have some interesting data which is also collected right now for a new paper in COVID times. So the ivabradine is close to about 10% in our population. But again, suppose we were to compare with the vegetation registries, look at the ESC heart failure long-term registry on recommended drug therapy at target dosage. This is again very important. At target was close to about 29% with an ACE and an ARB. Beta blockers close to about 17.5%, and MR is again about 30%. So most of the patients were not on even on target dosage in the Western world. And if you were to compare with the data from the US, which is the CHAMP heart failure registry, when they've looked at all the guideline-based therapy at the target dosage, what was found that only 1% were on all 4 guideline-based medical therapy at the target dosage. So I think we still have a long way to go. So we started looking at what initiatives we could do, and then we started doing a quality control program. This was actually done in Kerala in 8 hospitals, and I was also one of the co-authors in this paper. This was actually presented in the AHA and now gone for a publication. Locally contextualized quality improvement toolkit, which could be given to the patient and the hospital. And what we really looked at was what would happen with the physician updates, with the nurses' involvement, and the patient education, and again follow-up. So for this, we actually designed a checklist for the physicians to see whether the patients were on all the guideline-based medical therapy. We used a nurse to follow up these patients, educated the patients, and started following them in the house for a weight gain, whether they were on appropriate medications, and also to look at the quality of life. Very important statement. I actually have this particular slide, which I believe is very important in the present day context. This was a study where they looked at the discharge medications, and what they found that if a patient was prescribed beta blocker at discharge, there was a 93% chance of this patient continuing the therapy. Whereas if it is not started, there was only a 30% chance that they would continue a beta blocker. Similarly, in ACE and in ARB, if they were started in the hospital, 70% would continue that. But then if it were not started, only about 20%. So I think the important message is for the physicians to get educated about starting the guideline therapy while in the hospital, and then to see whether the patients are on follow-up therapy. And this will go a long way in prevention of future events. So the take-home message for the physicians is that to understand this heart failure have a high morbidity, mortality, by employing the simple checklist, which we did in our study and found to be very effective treatment and adherence strategies, considering additional approaches and offering pneumococcal vaccination, and also maybe to go the next step and see whether the patients would need a device or subsequent therapies like that. We also had an interesting look at our own data compared with 2019. I'm unable to give you the full data because this just gets gone for publication. What we have found is that we have the lesser admissions during the COVID time. I mean, the demographics and etiology are similar. Whether there is lesser admission was because of lockdown is not very clear. Demographics look the same, but there is a higher mortality, understandably so. But what is more interesting is about 8 to 10% of patients today are on ARNI, which was only about 3% in the last year. And beta blocker usage has also gone up. This is again like what we see in the Western registries. We are exactly on like what they're doing, because a lot of overwhelming data on ARNI and beta blocker also usage has picked up almost in all registries. So that is something which is nice to learn about even from our registry. And I'm sure with all the innovative strategies that we are trying to develop and algorithms and apps, this will go a long way in combating this deadly disease. I think at this point of time, I think I must share a publication which just came recently, a couple of days ago. Experts tout immediate quadruple therapy for heart failure reduced ejection fraction. This is based on the 3 pivotal trials on the ARNI, on the SGL2, as well as the MRAs. Extra 6 years of overall survival in a 54-year-old patient with heart failure reduced ejection fraction, added 8 years free from cardiovascular death or hospitalization, significant 3-year average boost in survival in patients among heart failure reduced ejection fraction who were more than 80 years old if they were on this quadruple therapy compared with the conventional medical therapy. And what is this quadruple therapy? People even say this as a 5 pillars. You start with an ACE, ARB, go to an ARNI, a beta blocker, MRA, and of course the new drug SGL2, which is even applicable in those patients even without diabetes. So I think this will help us in a long way, I mean, in a really big way to counter this deadly disease. So what have we learned from our registry so far? We understood there's a very high prevalence of heart failure. There's nothing new. Coronary risk factors are on the rise, but I think it's important to realize that we have an aging population. Chronic kidney disease is on the rise, so that's very important. Outlook is worse than cancer. If you don't treat them well, they come back, they get readmitted, and they die at least 20 to 30% mortality in the 1 year. very high in-hospital mortality, high rehospitalization, and we also find that the guidelines adherence is low. But then there is some improvement there in better usage of ARNI and also beta blockers in the country. So I think there is light ahead for heart failure in India. I definitely believe so. The heart failure registry, which we started as a pilot registry, encouraged by the success, we have gone into the second step now. We have actually going further, and we have think of having another 6,000 additional recruitment from another 25 centers, and the National Heart Failure Registry from ICMR. But this is only done for a very short pre-specified period in about, and looking at only about 150, 200 hospital admission, which is not a real life scenario. So I think that may not give you the exact data, but then we will have something to offer you in the years to come, at least to tell you where we are going ahead and maybe what else we should be doing in terms of tackling this disease. So I think be part of it. I would only request all the people who have listened to this to be part of the registry. The road to success is always under construction, and I'm sure there is always a better tomorrow. Thank you all for the kind attention.
Thank you, Dr. Jayagopal. Thank you for sharing this. I think this has been a very phenomenal or noteworthy contribution, epidemiological contribution about heart failure from our country. With this background, I would like now to invite Dr. Sandeep Bansal, who is our second speaker for the evening. And he will be speaking about, Sandeep is head of the department cardiology at Safdurjung Hospital, a very close friend, a very sharp clinician, and one of the most updated cardiologists all the time. So with this background, Sandeep, and he will be speaking about what is new, what are the new weapons which we have acquired in the last couple of years. Over to Sandeep.
Thank you, Dr. Rajput, and I must thank Dr. Jayagopal for having set the ball rolling. And in fact, as you shall see, we would have kind of ended with the same slide in the end of my presentation. So as we know, this has already been highlighted, and this is from a paper which has been adopted by Brown-Wald's heart disease in 2014, and it clearly shows as to how the things have changed over a period of time. And as we can see here, from the time that the first drug came for the management of chronic heart failure, that is ACE inhibitors, we've progressively seen that as you keep adding the drugs, the mortality keeps on reducing. And we've talked in details, Dr. Jayagopal has already stressed about this trio of ACE inhibitors, or RAS inhibitors as we may call it, beta blockers and MRAs. And when we talk of guideline directed medical therapy, this is what we are talking about the different NYHA classes and the recommended therapies. For example, the beta blockers and the RAS inhibitors would be recommended all across. And once the patient is in stage 2, you add these added drugs and devices. You have alternative drugs which are available in those patients who do not respond properly. And we have our surgical friends to intervene if the patients are still not responding. And that's the standard treatment that we've been following. Now, about 5 years ago, we had this new drug called LCZ696, which is popularly called as Entresto outside of India, and is called, as it is called, Entresto
Host has stopped sharing.
Vimada in India. And what we found was that over and above the RAS inhibitor benefit due to ACE inhibitors or ARBs, we could have an additional 20% reduction or 20% improvement if we used this new drug, which is called sacubitril valsartan, which is a combination of an ARB and a neprilysin inhibitor. Now, further down Over the last few years, as we are aware, we've had this new category of drugs called SGLT2 inhibitors. They have been used in different trials, and on the left side, we can see the different trials which have been done in diabetic patients. We came to understand that the SGLT2 inhibitors reduce heart failure in diabetic patients with and also without heart failure. Then we said, what about diabetic patients who have heart failure? There also they were beneficial. And finally, we have been able to test that this group of drugs are helpful even in those patients who do not have diabetes. And irrespective of whether they have diabetes or no diabetes, they are beneficial in heart failure. And this is based on a couple of recent trials. This is the summary slide. I'm not going into details of DAPA heart failure. I'm sure each one of us have gone through this over and over again, both in national and international meetings. So this is the summary slide, which essentially showed that if you if you added SGLT2 inhibitor dapagliflozin to the standard of care therapy, you reduced the primary endpoint by a whopping absolute 5%, from 21.2% to 16.3%. And this is a statistically very significant difference. And each component, there were three major components: cardiovascular death, hospitalization for heart failure, or urgent heart failure visit. The composite of this was statistically significantly reduced by the usage of dapagliflozin. There was a statistically significant reduction in cardiovascular death, and there was also a statistically significant reduction in hospitalization for heart failure. All in all, a stupendous trial with a stupendous benefit was presented by Dr. John McMurray in the European Society of Cardiology last year. Post that, there have been several analyses, several papers that have been published regarding the quality of life, regarding the analysis in diabetic versus non-diabetic patients, regarding the benefits that are accrued in terms of renal benefits, and benefits in the degrees of heart failure, relation with the ejection fraction. And all across the board, the benefits have been consistent. So in this trial also, nearly 55% of the patients were non-diabetics and 45% were diabetics, and the benefits were irrespective of your diabetic status. They were also, although the group of patients which was an ARNI was relatively small, but over a period of time, we have reasonable and sufficient data to suggest that this benefit is added on over ARNI. We are also talking of very stupendous renal benefits by the usage of these SGLT2 inhibitors. In fact, this is all through till now, we have only talked of the renal patients who have proteinuria alongside. And this is the first group of drugs where the renal problem or the kidney disease progression, irrespective of whether you have proteinuria or not, is benefited. So a stupendous benefit from this drug. Closer on heels, about 7 weeks ago, in the European Society of Cardiology, another trial using empagliflozin called the Emperor Heart Failure HFrEF trial has been presented. Again, almost similar results. As we can see, a fairly large trial of 3730 patients, and almost similar results as we saw in DAPA heart failure, highlighting what has been said but not been proven thus far that this is a class effect and not a particular particular drug, but it is by and large apparently a class effect for the patients of heart failure. So we have this new kid on the block, which is the SGLT2 inhibitors. The US FDA, as we are aware, has already approved dapagliflozin. I have had the good fortune of being a part of the group in India for the DCGI, which approved the usage of dapagliflozin for the indication of heart failure, irrespective of the diabetic status in India also. So this is what has already been talked about, that now we have the 4 pillars in the form of RAS inhibitors, beta blockers, MRAs, and SGLT2 inhibitors. Now, when we apply all these, we save a lot of lives. And what is believed is that a 2-year mortality can be reduced. If you don't use any drug, you have approximately a 35% 2-year mortality, which is reduced to under 10% if you are using all these 4 drugs. And that is indeed a stupendous benefit. Now, these are the drugs that we are kind of more familiar about. These are approved drugs, and these are already based on large trials. There are a couple of drugs which are coming up, which have shown promising results, and the next few slides will be dedicated to them. The first of them is vericiguat. It is a soluble guanylate cyclase stimulator, and we understand that it raises the cyclic GMP. We traditionally know that cyclic GMP rise takes place when the nitric oxide radicals are available, but this also directly stimulates, so it can act both through nitric oxide and independent pathway. And this was one drug which is being tested in the recent times. And this is again the summary slide from what is called the Victoria trial, which is presented at the American College of Cardiology and World Congress of Cardiology in 2020, about 6 months ago. And as we see here, again, a statistically significant reduction in the primary outcome, which was a composite of cardiovascular death, hospitalization for heart failure, and also, although the all-cause mortality was not reduced, the heart failure hospitalization was improved. Now, at this point, I would like to stress upon the utility of hospitalization for heart failure, because it has been seen, and my friends in the group, both Dr. Jayagopal and Dr. Sandeep Seth, they who've been associated with heart failure would vouch that across the world, including India, it has been seen that when your patient is hospitalized for heart failure, it is associated with a higher mortality in the times to come. So it has often been taken as a surrogate for increased mortality. And so reduction of hospitalization for heart failure is a very important endpoint. And in fact, the endpoint with which we started looking at SGLT2 inhibitors, and we found that they were so stupendously beneficial. The second point is the quality of life in heart failure. And we understand that SGLT2 inhibitors cause a tremendous improvement in the quality of life. We as physicians, we talk of improvement in survival. Well, as doctors, that is our major concern, but to the patient, what matters is the quality of life. And in DAPA heart failure, there was a statistically significant improvement in the quality of life. In fact, there were a lot of people who had a more than 5-point improvement in the Kansas City cardiomyopathy questionnaire score, which is a validated measure of quality of life. So coming back to Victoria trial, this highlighted that vericiguat used in sick patients with a higher mortality, this could actually reduce the composite primary endpoint, and this was primarily driven by reduction in hospitalization for heart failure. This is the data. This is the slide from the article on Victoria, and as we see, there was a statistically significant improvement in the primary outcome. The total hospitalizations for heart failure were improved, and death from any cause or first hospitalization was also statistically significantly improved, although the total deaths did not show a significant improvement. Now, shifting gears, we know that we've been traditionally targeting the neurohumeral angle on the heart failure with reduced ejection fraction. We go back to our medical schools, most of us were taught that this is associated because of poor contractility of the heart. And the central driver there is the reduced ejection fraction. So we have been looking at agents that include systolic function. We are aware that these inotropes, now they are being talked of as divided into calcitropes, mitotropes, and myotropes. If we recall, the examples of calcitropes include catecholamines and dopamine, dobutamine, epinephrine, and the cardiac glycosides, drugs like milrinone and levosimendan. Their action essentially was to alter the intracellular calcium concentrations. They have not proven to be beneficial over the long run. There are drugs like cardiac mitotropes. Some of us have used drugs like trimetazidine, and the older in our lot would have used perhexaline earlier. It is still used in some parts of the world. But the new kid on the block is this drug called omecamtiv mecarbil. This targets the myocyte actin associated regulatory proteins. And what has happened is that this is a cardiac myocyte activator. It increases the cardiac contractility and increases the number of, the force generators that are acting on the muscle. This is akin to something like a single person pulling the rope versus a lot of hands to grasp the actin filament to produce increased contractility. This has already successfully gone through phase 1 and several phase 2 trials, and currently it is in phase 3 trial, which is called the GALACTIC Heart Failure trial. This is available on the internet by John Tierlink, who's the principal investigator of this trial. And this is essentially typical heart failure patients with reduced ejection fraction. And the primary endpoint to be tested is first occurrence of cardiovascular death or heart failure event. This is an exciting drug, and this is the study plan. It is being tested now. It has been tested in acute decompensated heart failure, and it is now being tested in chronic heart failure. And to conclude about this particular drug, there's this large GALACTIC heart failure trial which is evaluating the safety and efficacy. And this is one drug which kind of shows promise in its class. Of course, the time alone will tell as to how it behaves in times to come. Another group of drugs which have come in are the drugs related to potassium. We are all aware of hyperkalemia being a very limiting factor, particularly in those patients who have comorbidities and who have renal problems. As this slide shows, as the number of comorbidities increases, the mortality that is associated with hyperkalemia keeps on increasing. And a number of drugs that we use for heart failure actually cause hyperkalemia. So we've been looking for drugs which could control the hyperkalemia, and we could continue to use the drugs which are required for the RAS inhibition. The first of these drugs, which is now available, the oral drug, there have been other drugs available, but what has recently brought these drugs to the fore is the fact that oral drugs are available. The Spitiromer is one wonderful drug. On the left side, we can see there are 3 trials at least which are available, and there is a large ongoing trial called the Diamond trial in specific population of heart failure patients. We also have another drug which is called sodium zirconium cryosilicate, which is undergoing a phase 3 trial currently after having undergone phase 1 and 2 trials. And these are the drugs which keep potassium under check. And this brings me to my last group of slides. What Dr. Jayagopal showed, that if we apply all these therapies comprehensively to our patients, and this is a slide from an Indian called, this is a paper from an Indian called Muthaiya Vaduganathan, and this shows that if your patient is 55 years of age, then you give him an event-free survival, which is 8.3 years more. And if your patient is 65 years of age, then you give another, you give a survival-free benefit of 6.3 years, which in itself is a very stupendous benefit. And this comprehensive therapy essentially means 4 drugs, and the conventional therapy means 3 drugs, which would include ACE or ARB and beta blocker with a spironolactone. Now, therefore, we've had these 3 drugs, and we are at this point of time jumping from here to SGLT2 inhibitors. We are jumping to drugs which will, help us use, which will keep potassium in check and help us use this. We have better forms of MRAs in the form of finerenone, which will be available. I did not touch upon this. And so, ladies and gentlemen, we have an exciting time ahead. And as Dr. Jayagopal said, at the Heart Failure Society of America meeting about 3 days back, the experts said that immediate quadruple therapy for heart failure with reduced ejection fraction patients, it should be started, and that is actually the way to go about. And at this point, I'll end my talk. I bring you greetings from one of the largest hospitals in Asia, the medical college, the OPD building, and these new kids, the emergency block, and that's my block, which is the super specialty block. Thank you for your kind attention.
Yeah, thank you, Sandeep, for taking us through to the new exciting developments which are happening in the field of heart failure. Now, we have a short panel discussion, and I think I would request Dr. Jayagopal and Dr. Sandeep Bansal to be around, and I will invite one of our senior colleagues, Dr. Modi, who has a lot of experience, and Dr. Sandeep Seth. And we will, like a rapid buzzer session, I'll pose some questions one by one, and I would request a very crisp and brief answer. Just a minute. Yeah, the first question is to Dr. Jayagopal. While doing this registry, you must have faced an encounter and have some opinion about why this, what are the main reasons why worldwide and especially in India, the guideline directed medical therapy is not that great. Dr. Jayagopal.
Yeah, well, when you look at the overall national picture, I think it's perhaps something on the physician's reluctance to see that these guideline therapies are followed up. So I think that's where we also did the heart failure quick program in Kerala, and we found that just a checklist actually improves the kind of complaints to guideline-based medical therapy. So I think it's at the physician's level, number one. Second important thing is, when they get discharged and when they go back home, the number of drugs, the more number of drugs that you have to take, the lesser the number of patients who are followed up on medication. And finally, we keep talking about all the 4 drugs today, but the cost is also a major factor. I think these are the 3 major reasons, I would say.
Yeah, I think conviction on part of physicians, cost and logistics are the main reason why utilization is poor. Now, as Dr. Sandeep pointed out, I mean, there's no doubt about there's so much of convincing data about ACE inhibitor, RAS inhibition and beta blockers and etc. Now, it's a very interesting, and as the last slide shows, that in American Heart Association, they say start all 4 together. Now, my question is that, that is usually not possible in most of our patients. So I'll ask Dr. Modi that if we have to rationalize or some kind of a practical consideration, what should be the sequence of therapy, which comes first and why, and, just a practical guideline.
Thank you, Dr. Rajput. And your question, it seems to me that what drugs first and what drugs can wait for the second stage or third stage. Of course, if patient is symptomatic, I think the diuretics are the first treatment immediately for relief. But then question comes amongst the beta blocker, RAS blockers, MRA, and other drugs. What should we do in which sequence? Now, there are not many trials on this effect, but there is a very interesting trial, which was, I'm sure all of you know that trial, CBS-3, which just was done for this purpose only, that whether beta blockers first or RAS blocker or ACE inhibitors first. And that trial very clearly showed, these kind of trials are very important because these kind of trials may not be taking place in your and my lifetime again. And we have to draw some conclusion from those trials. It clearly showed that early problems or early deaths occur mainly because of arrhythmias. So beta blocker should be the first drug. If you have to choose between ACE inhibitors and beta blockers, then choose first beta blocker, let the patient receive beta blocker for a while, and then find the opportunity to add ACE inhibitor or RAS blocker as soon as possible. So this was the only trial which guided me that if I cannot give both together, and you will come across patients, in many patients where blood pressure is 90 or 88 systolic, and you are very hesitant in starting 2 therapies together, and a patient's heart rate is 100, 105. So I will choose beta blocker, smaller doses, build up little bit of doses, keep the patient stable, and then add RAS or ACE inhibitor. So this is the only information from the literature. Otherwise, individual patient, you have to choose, have your own clinical sense and then choose which medicine first, which medicine later. That you can always decide. But the studies-wise, trial-wise, only CBS-3 tells me that beta blocker first before we use ACE inhibitor, in case you cannot use both together.
Yeah, I think, yeah.
And I'll just tell a word in consequence to the previous question to Dr. Jayagopal.
Yeah.
See, the low use of GDMT is a very, very important thing. And I personally feel that because recurrent hospitalization is a major feature in heart failure, in some way or the other, we should convince the insurance people that after discharge, the brunt of the medications expenditures should be borne by the insurance as they are bearing the expenditure during hospitalization. Because if they don't do it, patient is going to come back in 15 days time again or in 1 month time again. So once the insurance people are convinced that after discharge, at least for a month or 2 months or 3 months, they should continue to bear the cost of the medications. I think that will be very, very, very important thing. And then the physician will also not hesitate in writing, little bit of costlier drugs, which are very, very effective and which many times people don't write because of the cost. So insurance should reimburse not only hospitalization expenditure, they should continue reimbursing the heart failure expenditures even later. That's my feeling.
Can I just add something there?
Yeah, please.
Yeah, see, there was an interesting thing which we observed from the study. In fact, it was from the interim analysis. What we found when you looked at the prognostic factors, we found that if somebody skipped a diuretic, they were getting readmitted. In fact, this is I mean, the sheer problem of going to the toilet very frequently. So that makes them go down on the diuretics and they get readmitted. So this is everyone's, I mean, the data is that the more diuretics you use, the higher the mortality. But then there is an interesting paper which is actually in tune with our own thinking, that, the stoppage of diuretics is one of the major factors. We try to, this is such an inexpensive drug. And the second part, which Dr. Modi said about the insurance, when you look at the heart failure scenario at large in the country, the insurance coverage is very minimal. So I think it's perhaps very important for all the very expensive medication, but the simple things like an ACE, ARB, at least in Kerala, beta blockers are available free of cost. And secondly, there's, I think, an algorithm now which is available from the American Society, where it's recommended that you use small dose of both at the same time. So I think the concept where, you start both at the same time, ACE as well as the beta blockers in a very small dose, and then go upon the dosage later on, depending on the clinical scenario.
Very good. I think coming back to this RAS inhibition. Now, I have a question with Dr. Sandeep Seth. Is he around? Dr. Seth?
I'm there.
Yeah. Now, there's no doubt about paradigm heart failure trial that ARNI is better than enalapril. Now, what would you advise, considering the cost and etc.? And what is the practical tip? Do you still agree with the ESC guidelines, or you would favor the American guidelines, go straight with ARNI? Your comments, please.
See, I use a balanced approach. For patients who come with heart failure, I usually start them on ACE inhibitors or ARB. I don't start with ARNI as the first line of therapy. If they improve on just ACE or ARB, I stay on just that. But if within a month of therapy they are not improving, I do try to immediately switch to ARNI. I don't delay too much. Usually because of that, my first line of therapy is usually a ARB, because then the switch to ARNI is very fast. I don't have to wait for 24 to 48 hours. So I would often start as my first line of therapy as a drug like losartan, which is very cheap and easily available. I start with that and then switch to ARNI after that if the patient is not improving within a month or two. And there also, if necessary, I start with a very low dose of ARNI and then I build it up, because most of the patients I see are quite sick. So their blood pressure is actually ranging in the range of 90, 100, 110. So I would start maybe even with just one tablet or half a tablet once a day, and then build it up every 2-3 days. And then increase it every week or every 2 weeks till I reach 2 to 4 tablets of 100, 200 milligrams, gradually build it up. So I really believe that ARNI works very well because of that, especially the diuretic component in ARNI, the natriuresis which occurs. Patients have actually come back to me and said that the tablet which you gives me sends me to the toilet and that makes me feel better. So that natriuresis probably works very well beyond just the ARB component in the ARNI. So I believe in starting with ACE or ARB, but switching to ARNI if the patient is not improving very fast.
Okay, thank you so much. Now, Sandeep, just a very quick comment. Dr. Sandeep Bansal.
Yeah.
Now, we speak of ABC, ACE in RAS inhibition, beta blocker, and MR antagonist. Are we somewhere near to recommend that SGLT2 should be the fourth pillar in all, or there has to be some rider or some rationing?
I believe that, as I said, that was the last slide I showed, and that is actually based on pretty solid evidence. You have to use all the drugs, and you have to attack the heart failure in all the ways possible, because each pathway is kind of a different pathway, and the more the number of pathways that you attack, the better is going to be the prognosis. So while you can have limitations in terms of cost and issues like compliance, but based on science, all patients should get all these 4 drugs whenever they have heart failure. That's my simple take.
Thank you. Dr. Modi, just a quick question. MRA, everybody says there is a very solid evidence about MRA. But still, if you look into the trials, the utilization of MRAs is the poorest among the as compared to ACE and beta blocker. So what is the reason, and what would be your comment upon that?
See, Dr. Rajput, the MRA trials have shown the benefits, but we have to know that it's not like beta blocker or RAS blockers. Beta blocker, RAS blockers are kind of essential treatment. MR blocker is a helpful treatment in those patients where patients, in my practice, where patients do not have renal dysfunction, patients are not likely to go into azotemia or in hyperkalemia. So selection of MRA has to be individualized. It cannot be like every patient should receive beta blockers. So that's a dictum. Every patient, unless you have a reason not to give, should receive beta blocker. Every patient, unless you have a reason not to give, should receive RAS blocker, whether it is ASC, AR blocker, or ARNI. It's not like in MRA. There's no recommendation that every patient should receive MRA. MRA is reserved for very sick patients, like Ralph's trial showed that all patients were NYHA class 4, less than 25% ejection fraction. So they were the sickest of the sick patients where the MRA helped. Now in a class 2, class 1 kind of or prevention of heart failure patients, MRA has not been shown to be very effective. Now, another change in my practice in last couple of years is that since the time I've started using ARNI, almost like a primary drug, first drug. I don't use ARB or AC inhibitor necessarily before ARNI. Beta blocker and ARNI, once you are able to give these two drugs nicely in the good doses, then whether MRA addition is really helpful to the same extent as has been shown in the previous trials, I'm not very sure. See, the RALS was done when the beta blocker use was not regular in heart failure. It was done prior to 1999, 2000. And beta blockers was just picking up at that time. So use of beta blocker was not much in RALS trial. So I'm not sure whether MRA should be used in every patient. Yes, patient who is requiring loop diuretic, where I'm likely to produce hypokalemia, hypomagnesemia, likely to go into electrolyte problems, I'll definitely pick up one of the MRAs. I'll closely watch the creatinine and potassium at least, and make sure that patient doesn't develop renal dysfunction while on treatment. So we are all afraid of using MRA because of producing azotemia, hyperkalemia, renal dysfunction, and we use MRAs very, very selectively. I think that's the reason that internationally also the use of MRA is 10, 15, 20% range. It's not more than 20, 25% of the patients have heart failure receiving MRA. I hope it answers your query.
I think well taken. Just last question to Dr. Sandeep Seth. Ivabradine we see very often jumping the queue. Your comments, please. Is it like what is? I believe it has specific indications. And currently, how would you use ivabradine? Where and in what doses?
I add it to beta blockers quite often actually, because most of our patients don't really tolerate very high doses of beta blocker. Because I would add most patients to carvedilol or a low dose of metoprolol succinate. But if I can't get a reasonable dose high, then I would add ivabradine quite fast, and I would start at about half a tablet once a day, twice a day, and then go up to 5 milligrams once, and then ultimately twice a day. So I'm quite fast in starting ivabradine, because ultimately we do want a reasonable control of heart rate. At least I'm not able to get the heart rate down to 60, 70, because if I try to achieve that, invariably the patient decompensates. But if you can get a reasonable dose of ivabradine in, even if you can keep the heart rate down to a reasonable rate of 70, 80, that improves the patient to a reasonable rate. So I don't think we need to target a heart rate of 60 or 50 as it was in the SHIFT trial. But if we can keep the heart rate down to even 80, even with exercise, that is a reasonable target. So getting some ivabradine in along with the beta blockers is a reasonable target. I think that's how I do it.
Yeah. So just a balance of the two, because we know that in most of the time we are not able to push the beta blockers to the desired dose. So just combining the two. Just one last question with Sandeep Bansal. Sandeep, in one line, half a minute, use of digoxin.
I do use it, but towards the fag end. I mean, when I have my back to the wall, I've used all the drugs and the patient continues to be symptomatic. Remember, the the proved and the radiance trials, they showed that it does decrease hospitalization for heart failure. So I do use it, but I use it at the fag end. That's it.
Okay. So I think we come to end of this interesting session, and I must thank all the speakers and panelists to be upfront and commit themselves to the views. Thank you very much. Thank you. So we move on to the next session, which is a symposia on post-ADHF management. And this session has got three eminent panelists. Dr. Vijay K, who is a senior nephrologist, needs no introduction to this audience. He is currently head of the nephrology in Max Hospital. Dr. Gokhale, who is a very well-known cardiac transplant and specializes in management of heart failure, surgical aspect. Very vast experience in this field. And Dr. Das, who is past General Secretary of CSI and a very senior interventional and clinical cardiologist with a keen interest in heart failure. So with this, I will get the ball rolling for the next session. And the theme is that after hospitalization, there's a typical story. Patient gets admitted with heart failure, they receive the treatment, and they are discharged. And the first year is very crucial. 25% of those who are discharged get readmitted, and 1 out of 8 or 9 is not alive by the end of 1 year. There is a hospital mortality, which is very high, especially in India and Asian countries, and the post-discharge mortality is also very high. There is clear guidelines that even during hospitalization, every effort should be made to continue guideline-directed medical therapy with minor adjustments according to the clinical situation. And if they are not on optimal medical treatment, there should be a sincere effort to start guideline-directed medical therapy. And this is probably the best time to start the therapy. Our next session is to explore various aspects of this post-hospitalization management of heart failure and how to go about that. Now, my first question is to the cardiologist, Dr. Das. Are you there, Dr. Das?
Yes, I'm
First of all, a big thank you and a welcome.
Thank you, thank you.
Now,
am I audible?
Yes.
Okay, fine.
Now, we have, so far you have heard that, hospitalization and mortality, these are the two important pillars what we are aiming to reduce in management of heart failure. So what is the impact of repeated hospitalization in general and especially in Indian population? What is the evidence so far?
Yeah, this has been a very much important challenge. I always give an analogy of the entry of the re-entry and re-entry of the thief to my house. Actually, if you allow the thief, if you give the chance to the thief to enter, definitely he or she will take the chance to re-enter. And that exactly happens with the heart failure also. You are giving a lot of chances to the disease process and not taking the proper care, not following the guideline-directed medical therapy, automatically there will be the chance of developing this complication, that is the hospital readmission. Now, this hospital readmission, I think it has been highlighted quite adequately in the earlier session, that once the rehospitalization or readmission occurs, always there is a chance of greater damage to the myocardial cells, and that actually hastens the process of the the heart failure further. So in essence, heart failure begets heart failure. So that sort of thing happens. Now, in the Western countries, they have taken up these issues of readmissions by taking the help of not only the heart failure specialists, but also the heart failure nurses. But in India, actually, the main problems are logistics, main problems are the finance, and also there are problems of the healthcare service providers. And that has resulted in more readmissions, because they come so late to the hospital that they get very sick. And once they are out, because of the same factors which led them to the readmission to the hospital, late actually, so that recurs and ultimately readmission happens. Now, it has been found that almost 30% of heart failure patients are readmitted in 1 year in Indians, and also 24% of the patients actually get readmitted more than once in a year, though there is no much of difference between the different genders. However, it must be re-emphasized that out of 3 patients, every patient gets readmitted at least once in every year. So with this background, actually, it's a very much a challenge, and we must take up the issue of readmission. There are so many aspects by which we can take care of the hospitalization, readmission, or hospital rehospitalizations, and that we will discuss in greater detail in subsequent time.
Yeah, thank you. And I just supplement that, low use of guideline-directed medical therapy is also one of the reasons, and besides progression of the disease. Now, the next question is to Dr. Gokhale. Most of the time, when patient goes for a surgical procedure, general opinion of the patient is that I have undergone a major procedure. The drug should not be so important now. So in your experience in post-surgical and post-revascularization patient, what is the importance and what are the parameters to ensure GDMT in heart failure patients? Dr. Gokhale, please.
Thank you, sir. See, as we all know, not only in Western countries, even in India, the commonest cause for heart failure remains to be a coronary artery disease, ischemic heart disease. As many as 2/3 of the patients with heart failure, the reason is coronary artery disease. And apart from medical management, many of them often require either angioplasty or bypass surgery. We can easily say that someone has got a triple vessel disease, significant LV dysfunction, graftable targets, even if the ejection fraction is 10 to 15%, surgery is the recommendation. There's no doubt. But when coming to the surgery, we are always worried as surgeons because theoretically it is correct, but the mortality remains very high in these patients. It almost doubles when the ejection fraction comes down to 15 to 30%, the mortality goes up. So this ejection fraction remains a strong predictor of mortality after revascularization, not only for deaths, as well as for readmissions. As you can see here, as many as 30 to 35% of the patients require readmissions in a couple of years. One of the reasons, as we have been discussing all this time, is I'm very happy to see the discussion in the country today, so much awareness about heart failure and medical management. So we often say we are behind developed countries, but in this situation, there is a trial called STITCH trial, which looked at patients with a severe LV dysfunction, coronary artery disease, whether medical management is as good as surgery or anything has got a better thing. In that decision, they found that in abroad, there is only 6% of patients are on GDMT at admittance. These are patients with severe LV dysfunction, coronary artery disease. At the time of discharge, only 11%. So we are not far behind. I mean, we cannot compete in this. We have to do better than that. But that tells us that most of these patients after revascularization, either because patient is not prescribed by surgeon or cardiologist, or because of various reasons patient doesn't take, the mortality remains very high. So use of medications is very suboptimal unless we add this GDMT, whether to do angioplasty or bypass surgery, we are only temporarily improving the blood supply. But the main reason remains behind. There is an atherosclerotic process or remodeling of the ventricle. Unless we help it, these patients are not going to stay alive for a long time. And it's very important at the time of discharge that we optimize some medications initially. See, when we give the GDMT, as you can see in this slide, the mortality comes down, the survival improves, not only in the immediate perioperative period, but at the end of 3 years, 5 years, 10 years, still almost 1/3 of the patients get benefited. That means You lose 1/3 of the patients if you don't give optimal medical management, GDMT along with revascularization. So saving 1/3 of the patients is a huge figure. I think we all should concentrate, whether surgeons or cardiologists, that heart failure is something which need to be tackled properly, irrespective of revascularization process. Thank you, Rajiv.
I think in one line, I think once the patient is about to go home after a revascularization procedure, we must spend some time with them,
Yes.
because they have a notion that I have gone through all this major procedure. Probably medicines are not as important now. And you won't be surprised, many of our patients asking, I've gone surgery, still I have to take so many pills. So that is the crucial point in highlighting, then you're going to be much better if you continue with that. Now,
in fact, at the time of discharge, you may not be able to start many of these things, especially following surgery. But every time they come for a follow-up, we have a note on our table. Is the patient given dietary advice? Is the patient on any of these following drugs? Can we increase the dose of these drugs? These 3 lines are there on our consultation table just to make sure that we don't miss.
yeah, I think well highlighted. That another important question which often complicates the scenario is existing or worsening renal function. So are ADHF patients at an added risk of developing renal impairment? Does it have prognostic importance? Does it affect the choice of medication? And to answer this question, I would request one of the most eminent nephrologists of our country, Dr. Vijay Kher.
Thank you, Dr. Rajput. It's a pleasure to be part of this elite panel, and I sort of feel very, very good being part of this. And I must thank you and Novartis for giving me this opportunity to talk to you. As you said that, yes, kidney failure and heart failure exist together. About 30 to 50% of patients of chronic kidney disease have heart failure. Unfortunately, many of these patients may not be labeled as heart failure itself because fluid overload is sort of misjudged in these patients, and many of them may not be labeled as heart failure as such. And if you look at heart failure patients, then 30 to 50% of patients will have some renal impairment in patients of heart failure. And why is it important is that mortality in patients is already very high in patients with heart failure. When they have renal dysfunction, mortality gets added another 20 to 30% higher mortality with renal failure. Now, are patients of acute heart failure who get admitted into the intensive care unit, are they at higher risk of worsening of renal function? Yes, they are, because these patients are put on large doses of diuretics to get them better as far as acute heart failure is concerned. So diuretics will produce volume depletion in these patients, and therefore they may be already on ACE and ARBs as well. And because of the renal hemodynamic, which is what is shown here, this is the normal structure functional relationship at the glomerulus, or you have an afferent arteriole and an efferent arteriole. And normally, even if the blood pressure goes down, kidney is able to auto-regulate. It maintains the glomerular filtration rate because it dilates. It causes dilatation of the afferent arteriola. And because of the renin-angiotensin system, the efferent arteriole gets constricted, and therefore the glomerular pressure is maintained and the glomerular filtration is maintained because of the afferent arteriolar dilatation. However, when patients are put on ACE inhibitors on these, the efferent arteriole dilates, and that's the reason why both with ARNI as well as with ACE and ARBs, if you give them in a patient, especially if they are volume depleted, there would be a sudden decline in GFR. And that happens basically because of this autoregulatory alterations at the glomerular tubular basement membrane, glomerular tubular interactions of the tubulo-glomerular feedback. The renal hemodynamics at the afferent and the efferent arteriole and the glomerulus is affected, and that's the reason why there may be. But don't get worried about this sudden decline which happens in whether you put patients on ARNI or on ACE inhibitors or ARBs. That is temporary one. It recovers usually, and then
as you follow these patients on a long-term basis, the decline in GFR is much lower in patients who are on ACE, ARBs, or ARNI. So one should not worry about the sudden decline in renal function. And same is true also when you use diuretics in patients with acute heart failure. You suddenly find that the creatinine starts going up. And it has been found that those patients who actually show diuresis are the ones who show this worsening renal function, but they survive much better than those who do not show worsening renal function. This is an acute reversible worsening of renal function which occurs because of volume depletion and the ACE and ARBs that the patients have been put on. One shouldn't worry about it. One should monitor it unless it progresses to a progressive more than 30% decline in renal function. You shouldn't worry about the sudden rise in the urea and creatinine in the patients who are admitted in the heart commands or heart stations in the hospital. So that was what I would want to say at this stage.
Thank you, Dr. Kher. I think beautifully summarized that this transient phenomena is not to worry about, but just a very close watch. Now, markers are very important in management, and in fact have become more important in the last 1 decade. And I think many people say that it is like HbA1c of heart failure is like markers NT-proBNP. So what is the role of measuring NT-proBNP in ADHF patients? Does it tell about prognosis, future direction, future treatment? And I would like Dr. Das to comment on this.
Yeah, this is a very, very important question. So for the diagnosis and prognosis of the ADHF is concerned. In fact, as you have highlighted that this really is comparable to the HbA1c in heart failure. Now, there are different markers, as you know, that TROP-I, TROP-T, then the ST2, then also galectin, then even CRP. But out of all these, it has been found that the NT-proBNP has been a very, very significant biomarker in the management of heart failure patients. Now, why this is important? Because on one hand, you can get the diagnosis when the marker level is raised beyond, say, 400 picogram. So you can diagnose it that yes, you are possibly dealing with heart failure. Now, if it goes beyond certain more level, say in terms of 1600 and so, then in a sort of normal patient who is not elderly, up to say 55 years of age, you can attribute the cause of the rise is due to the heart failure itself. And similarly, in terms of the prognosis also, as the markers go on increasing and increasing, you know that the damage to the heart muscles is happening progressively, and thereby the dilatation and the activation of the BNP mechanism is happening, and ultimately there is rising this BNP and NT-proBNP levels. And on this basis, actually, for the diagnosis, the various guidelines, they have put it as a class 1 indication for testing. So class 1 indication means there are a lot of evidences that it really supports the validity of the tests. So that's why in acute setting and you can use the measurement of NT-proBNP more than 300 to 400 picogram per milliliter as a class 1 indication. And that has been emphasized even in the American College of Cardiology as well, especially when the patients are ambulated and suddenly they deteriorate. Then in that background, as a class 1 indication, actually you can put this test as a diagnostic marker. But what is interesting in the biomarkers is that there is a little bit of higher level of biomarkers in the elderly patient, especially when it crosses say 54 or 55 years of age, and also when they cross more than 75 years of age. Say, for example, if you take the 50 to 75 years of age, then you will attribute the biomarkers more than 900 picogram per milliliter as the diagnostic marker. And in case of more than 75, it is actually more, if it is more than 1800, then only you will take it as a diagnostic marker. Now, so for the prognosis is concerned, again, on the it has been remarkably shown that the Kaplan-Meier's pathway actually separates quite early, and ultimately there is a increase in the rehospitalizations and also increase in the mortality, almost to the tune of fourfold if the BNP rise is happening relentlessly. And that is why possibly it's a very, very important marker which we should put emphasis on.
Yeah, very well summarized, Dr. Das. I think in one line, it has got diagnostic, prognostic, and helps in management. The only thing I would like to say that possibly we are not using, mainly because of cost factors, maybe, we are not using as often as we should use. Like if you admit a patient with acute heart failure and his BNP is 4600, and after 4 days, 3 days, it is 2100, it will give you a lot of confidence that you are in the right direction. Many times because of the cost cutting, we skip that part and we reevaluate only when the patient is not improving. The only thing is that the clinical judgment remains important because there are so many false positive in BNP. So clinical judgment remains important in interpreting these BNPs.
Yeah, now, I completely agree with you that the use is not that very high, but definitely it is increasing gradually, especially in the corporate hospitals and private setups. And gradually the things are being taken up by the public hospitals as well.
Okay. Now, coming back to Dr. Gokhale, I think we are now teasing surgeons also with medical questions for last decade. Now, what is the role of measuring NT-proBNP when you are taking patients for revascularization? It is not just for management, but say for surgical standpoint of view.
As you rightly said, Dr. Rajeev, what's happening is most of the patients who are coming for bypass surgery these days have got some amount of left ventricular dysfunction, at least 50 to 60% of these patients. So today, if we want to survive, if we want our patients to survive, we need to know about the medical management of this heart failure. Without that, some of these patients come only to the surgeons for the next 2-3 months, and by the time they go back to the cardiologist, we often lose them. That is a reason why surgeons also need to know about it. As you rightly said, most of the times we don't make use of NT-proBNP. We use a clinical judgment. The cardiologist refers to as a patient with a heart failure. In an acute heart failure with a VSD, a situation like that, we make sure that these patients are very well stabilized, because if you can go back to one slide before, it has been shown clearly that even in a PTCA, the mortality is increased by almost 60% if you don't control them properly and do a angioplasty. Now imagine doing a surgery, putting a patient to a major trauma without controlling heart failure. That is when we have a doubt patient is controlled adequately or not, that is when we use the NT-proBNP. Otherwise, we use a clinical judgment. And many make sure that these patients are on these drugs. As you can see very well, we have been using ACE inhibitors for a long time, but with the addition of sacubitril valsartan, these patients, the NT-proBNP levels come down very fast with this combination of the drug, within say about a few weeks compared to the enalapril. So if the heart rate, blood pressure, renal parameters, all these permeate, we encourage these patients mostly on these drugs of a combination of sacubitril valsartan or ACE inhibitors. And many of these patients get stabilized. That is when we take them up for surgery. Otherwise, the mortality after surgery immediately will be very high. So that is when we use selectively the NT-proBNP levels.
I think it helps us in timing, preparing the patients adequately to have the best surgical outcome. And yes, there is evidence that not just for medical treatment, but even in surgical arm, if your patients are on ARNI, they do better than as compared to ACE inhibitor.
Yeah,
So
almost 25% reduction.
excellent. So all the time, whenever we measure NT-proBNP, and if kidney functions are not normal, then we are very jittery about it. How important it is? Is it being? How much is contributed by cardiac, and is it artificially high because of the renal? So I'd like to ask Dr. Kher how to interpret these BNP levels in context of renal impairment in patients with heart failure.
Yeah, I think as you said, Rajiv, renal dysfunction will raise the NT-proBNP levels, and the cutoffs which have been set for diagnosis of heart failure are no longer acceptable in patients who have renal dysfunction, because they would be elevated in renal dysfunction without heart failure as well. So there is a contribution of renal function which raises the level. However, what has been seen is that even though the cutoffs may be at the higher levels, but when you have patients with heart failure and renal dysfunction, and if the heart failure is significant, then the levels of proBNP, NT-proBNP will be very, very high in these patients. And what's been seen is that ACE and ARBs, as well as sacubitril and valsartan combination, the ARNI, whenever you use these drugs, whether the patients have renal failure or the patients do not have renal failure,
I will ask you to introduce Sandeep Seth
on NT-proBNP is similar. So there will be a greater decline in NT-proBNP even in presence of renal dysfunction with ARNIs and these. That's why that's more important, that ARNI as well as ACE and ARB inhibition would decrease, and ARNIs do it much more than the ACE and ARBs as far as NT-proBNP in patients with renal dysfunction and heart failure.
And I think even in patients who had eGFR of less than 60 and more than 60, there was a similar reduction in NT-proBNP with ARNI as compared to ACE inhibitor. So I think we need to have some higher threshold cutoffs in patients with underlying renal dysfunction, but they are not completely, they're not test. We cannot use them. They can guide us, and they still remain useful. What is the best time to start therapy of heart failure? And I think there cannot be a better setting as far as patient and doctors are concerned. Patients are also very susceptible to follow your advice when they are hospitalized. So how do you start the guideline-directed medical therapy in ADHF patients? And what is the evidence about pre-existing and about ARNI regarding starting them during hospitalization? Dr. Das.
Yes, that's a very, very important question. In fact, what we have learned all throughout these years after this particular molecule has been initiated, that we are focusing more on the acute heart failure cases and more on the chronic heart failure cases, and not focusing much on the recurrence of admissions and the rehospitalization issues. Now, to settle these issues, actually, two trials have been done. First is the Pioneer Heart Failure trial, and the other is the Transition trial. And they have adequately shown that if the ARNI is started early, and then you get much more benefit in terms of not only reduction of the NT-proBNP level, as it has been discussed by all of us, actually, that they really do decrease, and they not only decrease it, but also in terms of the morbidity, further rehospitalization is also taken care of by the early start of the ARNI. And Pioneer Heart Failure study, they specifically mentioned about the lowering of the ARNI, and it has been shown that even as compared to the SCE or ARB, the ARNI almost takes over the function of reducing the proBNP almost in a week or so. And then the separation between the decrease in the level becomes much more prominent in case of the ARNIs. And that is why the standard practice nowadays is not to wait for the ACE and ARB to respond and all, because it has been adequately shown that they really decrease the proBNP, which is much more associated with the rehospitalization as well as the mortality benefit. So why shouldn't we try it early? And that has been again re-emphasized in the transition study, which has shown that if you start it early, then gradually the various parameters they get improved. There is reduction in the hospitalizations, and as you know that with the recurrent of hospitalizations, there is always increased mortality, and that actually is taken care of by starting the drug quite early. And there are various statistical phenomena that this can reduce the composite points by about 42% when we are using ACE or ARB versus the ARNI. And same way, there is also the reduction in the cardiovascular death almost to the tune of 40% if you use the ARNI early rather than the ACE or ARB. So with that background, actually, one must transmit this information and knowledge to all across the board that we should not withhold the benefit of ARNI, even if it is costly. There are so many methods by which you can reduce the cost even, and those will have to be applied in the patients. Then you can actually give much more beneficial effect in terms of reducing not only the rehospitalization, but also the mortality of heart failure.
Thank you, Dr. Das. I think very well summarized. And I think this is probably, ARNI has the maximum evidence that we should start this therapy right after the hospitalization as compared to other pillars. So with this, we come to end of this interesting session and about ADHF patients, how to optimize, how to use biomarkers, and how to start medical therapy, optimal medical therapy. Thank you to all the panelists.
Thank you.
Now with this we come to the last session, and for this I've kept it very interesting session by Dr. Sandeep Seth, because as the transplants are picking up in India, we need to update ourselves regarding pre-transplant and post-transplant management of cardiac patients. I know I'm being unfair in asking him to summarize this in 15 minutes, but I have requested him just to update the new developments in last 5, 6, 7 years and to be short, so that we can have some time for the last session. I would request Dr. Mukesh Goyal to say a few words before we start. Dr. Mukesh?
Yeah. Good evening. So it's my pleasure to have Dr. Sandeep Seth here. He's a main proponent of heart failure therapies, heart failure clinic, and heart transplant services in whole of North India. And he's rather a go-to person for any query on heart failure and heart transplant. He's a professor of cardiology at All India Institute of Medical Sciences, New Delhi. And he has one of the biggest experience in heart failure management, running a heart failure clinic and heart transplant patients in India. So I invite Dr. Sandeep Seth to please enlighten us on heart transplant pre and post management. Welcome, Dr. Sandeep.
Thanks, Dr. Rajput, for giving me this chance. I'll just start my slides, please. So the majority of patients with heart failure, almost 95% of these patients can be managed with good medical therapy. It's only 5% of these patients who will need something beyond medical therapy. And that's where therapy like assist devices, LV assist devices, or transplants would come in. And that's what I'm going to talk about in the next 10 to 15 minutes. And I will try to keep this talk relatively simple. So heart transplant as a therapy started in 1967 when Christian Bernard did the first heart transplant in South Africa. The story of heart transplant in India started in 1994 when Dr. Venugopal did the first successful heart transplant in India. The first transplant was done in 1967, but the patient died pretty soon. The first few transplants all actually died pretty soon because the surgeries were successful, the surgical technique was successful, but the surgeons had not understood that post-transplant, post-surgery, there were going to be a number of complications, there would be rejections, there would be a number of infections which they had not anticipated. It's only in Stanford where the techniques had first been designed that some of the surgeons, some of the doctors continued. This was the main person there, Shumway, whom we really don't talk about much, who continued to work on this, and he understood the physiology, the pathology behind transplants. So after the initial decline, we managed to achieve good results with heart transplants. We understood that there was a concept of rejection after heart transplant, so they would get major rejections. We learned to pick up rejections by doing biopsies from the heart. Then came the discovery of immunosuppressants, which were relatively safe, like cyclosporin. Initially, we used very high doses of cyclophosphamide steroids, which were very toxic. We understood that the infections that you would face would be very severe, unusual infections like these infections, like fungal infections, which would actually create fungal balls, as you can see in this chest X-ray. So the initial problems that were faced were severe rejections, severe infections. Once we learned to master these, the heart transplants became successful. And these are the results that you have right now. After the initial decline, currently about 3,000 to 4,000 transplants are done every year. After a good successful transplant, if the patient can survive the first 3 to 6 months, he can easily achieve a good 10 to 15 years post-transplant easily. So now let's see what are the steps involved in achieving a successful transplant. So who needs a transplant? There's a very simple algorithm. It's called I need help. So patients who are requiring recurrent admissions for infusions of inotropes, patients are persisting in staying in NYHA class 4 or their BNP or NT-proBNP is staying persistently high, who are having end organ dysfunction, persisting renal or liver dysfunction, which is not improving. Exercise capacity has gone down. The 6-minute walk test is less than 300, or their exercise capacity has come down, getting recurrent defibrillator shocks, recurrent admissions, edema is persisting, the doses of diuretics are very high, sodium has gone down. They can't even be given the ACE inhibitors or beta blockers that we have talked about since the past 1 to 2 hours. So if they have any of these markers, then you know that these are the patients who are going to need something more than just the medical therapy. So they will need possibly a transplant or an assist device, a very simple algorithm to use. But you have to ensure that you have taken care of all possible reversible causes. That means if it's a patient with rheumatic heart disease, you've tried your best to replace the valve. If it's a patient with ischemic heart disease, you've done everything possible to either do angioplasty or do surgery, repair any possible leaking valves. In terms of medical therapy, you've done your level best to give all possible drugs. You push the drugs to the maximum possible. You're taking care of any iron deficiency, any thyroid dysfunction, anything possible that you can reverse before you think of irreversible heart failure. Then you assess what is the severity of heart failure by looking at all organ function, look at the natriuretic peptide, look at the exercise capacity. At the same time, not every patient can go for an assist device, not every patient can go for a transplant. You can't just say that the patient is now ready for a transplant. If the patient is elderly, the patient will not tolerate, will not fight for a transplant. If the patient has active infection, for instance, active tuberculosis, patient has diabetes with multiple end organ damage, patient will not be suitable for a transplant. If you know the patient is not compliant with even his routine medication, doesn't have a support system, doesn't have a supporting family, these are not the patients who will go for either a assist device or even a transplant. So you have to be sure that you can't just send any patient with end-stage heart failure for a transplant. You have to be sure that he will cherish that organ and he will be able to support that new organ. At the same time, they should not have a very high pulmonary artery pressure, because if the pressure is very high, immediately after the transplant, the right ventricle will fail. These patients, you have to get the PA pressure down, or have to think of a heart-lung transplant, which is itself a very big surgery. So doing a lung transplant itself becomes a major problem. There's also the kidneys, the liver, and all should be functioning well. If they have additional lung disease, they have severe bronchitis, then again, you have to start thinking of a heart-lung transplant. Now, what do you do with such patients? Once you've decided that the patient is fit and suitable for a heart transplant, we start working up these patients, make sure that there are no contraindications, do a simple set of blood tests. You consult the various other departments like the respiratory team, the gastroenterology, nephrology. Ask the psychiatrists, the dental teams, all other teams, as you would before any major surgery, involve other teams. Look at all the other organs, look at the blood vessels. We do a simple CT scan of the whole, literally the whole body. Because after surgery, if there's any complication, you should have a pre-op CT scan to compare with. We look at the cardiac evaluation, including a do a catheterization to look at all the pressures. We again look for any reversible cause which might have been missed by the referring cardiologist. We look at what is called the panel reactive antibodies, which is basically looking at preformed antibodies against the donor heart. We do a infection serology. So we look at all the unusual possible infections which can occur after surgery. We also look at hepatitis B, C, look at HIV. Look at possible infections in the skin, look at cultures, do a MANTO or do a quantiferon gold. And as per need, we also screen for possible malignancies. We complete the vaccination. Children will complete the relevant vaccinations, and adults will give a hepatitis B vaccination, pneumococcal influenza vaccine. So basically, we try and make sure the patient is fully ready for a possible transplant. We also assess the patient's overall fitness for a surgical procedure. So we assess what is called the frailty index by various indices which are available. You can use any index which way you are comfortable. Similarly, once we are ready with the patient, at the time that we get a call for a possible donation, we also screen the donor heart. Again, this is done at multiple levels. I won't go into much detail, but basically we want that the heart that we are procuring is a perfect heart. So the assessment is done at multiple levels. First, by the donor hospital, then by the first team that goes there, which is usually the person who's given the call, then by the transplant cardiologist who will assess by doing the echo, looking at the ECG, chest X-ray. Occasionally, we will try and do a coronary angio. If the patient is above 40, usually it's not possible to do a coronary angio. The final screening is obviously done at the time when the heart is being procured. The surgeon looks at the heart on table and ensures that everything is okay. We also screen the donor heart and everything for infections. So this is how rigorous it is when you're trying to do a heart transplant. You want to be perfect before doing the heart transplant so that you don't face any problem after the heart transplant. Post-heart transplant care. So the problem is that all these things have to be done before the heart transplant, because you know that after heart transplant, the patient's own heart is gone. You're facing a patient who has a heart from another person. Patient will have problems. Patient is going to be on very strong immune suppression, so he will get a number of infections because you are trying to give him immune suppression to prevent a rejection. Later on, even if he's gone through the first 3 to 4 months, he will still be prone to a variety of infections, which will keep changing. The pattern will keep changing. Initially, he will be prone to post-surgery infection. Later on, the infection will set in because of chronic immune suppression. So infections like chronic viral infections, tuberculosis, fungal infections will come in as the immune suppression becomes stronger and stronger. Rejection over time will become less and less, but infections will become more and more. As the immune suppression becomes stronger, some of the immune suppressive drugs will cause hypertension. After 1 year, because of the immune suppression, allograft vasculopathy, basically which is coronary artery disease of a different kind, which is concentric, difficult to treat, also sets in after 1 year. So the different problems keep coming in. It's not that these problems are very, very common, but these problems have to be anticipated and tackled. So you look for rejection, look for rejection by doing repeated biopsies. You keep monitoring the patient by echocardiography. This is how the rejection looks like. Basically, there are multiple lymphocytes along with necrosis inside the myocardium. These are treated by increasing the dose of the oral steroids if it's a very mild rejection, by giving pulse steroids. Sometimes you have to give very strong antibodies like ETG and OKT3, and if sometimes you have to do plasmapheresis. So depending on the kind of rejection, you have to give very strong therapy for that. To prevent the infection, you have to give very strong prophylaxis, which includes 4 to 6 months of Valgan cyclovir for CMV. You have to give a cotrimoxazole for 1 year, and you have to give voriconazole for fungal prophylaxis. So these are drugs which are fairly toxic, and they're also very, very expensive. So these are some of the things which contribute to the cost of therapy post-transplant. So now I have already talked about the kind of infections that we face. Early infections are quite often bacterial because they're related to surgery. Later on, the infections because of immune suppression set in. So drug infections like CMV, fungal and tuberculosis infections come in after the first 3 months. These are the kind of immune suppressives that we give. We basically give what is called triple immune suppression. So there'll be one of these drugs from the calcineurin inhibitors. We will give either cyclosporin or tacrolimus. Usually, currently, we are giving a drug like tacrolimus. There'll also be an anti-metabolite. Currently, we're using mycophenolate mofetil. We also give steroids. Steroids are given in a very high dose in the first 2-3 months, and they're tapered down. Usually, we are not able to taper down steroids totally, but in some of the teams are able to taper off steroids totally after the first 1 year or so. But these are triple regimes that we're using in most of our transplant programs. After the first year, we can get allograft vasculopathy, which is concentric coronary disease, which is very difficult to treat because it is concentric, very difficult to pick up by simple angiography. Often you need a CT angio or intravascular ultrasound to pick it up. It is often asymptomatic and cause asymptomatic heart failure because these hearts are not having a neural connection. So the patients often they will not have angina. So the event will be a arrhythmia or sudden cardiac death or progressive heart failure. So it's very difficult to pick up unless you do an investigative procedure. This is just some of our experience that we have published recently. The first few years, we were doing very few transplants because organ donation in North India was not very common. About 4 or 5 years ago, there was a decision that AIIMS would fund each organ retrieval. So then the number of heart transplants started increasing. As we increased our transplants, then the complications also started increasing as would be expected. So this is roughly our data. From 2014-15, there was a rapid increase in the number of transplants. And as was expected, as we increased rapidly, our complications started increasing. So we had a number of rejections, we had a number of infections in the first 2 years. So 2014-15, first 2 years, there was a very rapid increase in the number of transplants, rapid increase in complications also. So at that point, then we started looking at what was going wrong. Next 2 years, then we changed a number of things. We changed the way we were selecting the patients. We changed our protocols. We looked at all the protocols in the various parts of India, looked at protocols outside India. We changed our protocols, increased our asepsis techniques, changed our prophylaxis post-transplant. With that, our complications from 2016-17 came down. So just doing a proper audit and being very careful about protocols and looking at problems and then correcting them made a difference. So this I won't go into the details of this. These are some of the complications we saw: fungal infections, infections in the spine, tuberculosis of the spine. We had renal dysfunction, arrhythmias. So some of the problems which we had. So what we basically did was we started tapering off the steroids very rapidly. We also found that rejections were occurring much more even in the second year. So we started keeping our tacrolimus cyclosporin levels slightly higher in the second year instead of tapering them fast. And we became more rigorous in following up the patients with echo and blood work. And we kept being rigorous in the second year also. So currently our patients who are surviving the longest are surviving as long as 13 to 15 years without complications. These are just a glimpse of some of our patients working in their workshops, driving. This is just a glimpse of some of our teams. The patients are there with their families along with the physiotherapists, dietitians, doctors. You can see Dr. Balram there in between. This is Dr. Venugopal with the former Prime Minister, Mr. Vajpayee, with Kapil there. Just on my last slide, this is just a snapshot of where we are in India. In India, as what we had evaluated around July, August, we have done more than 1,000 transplants. Most of the transplants, as you can see, have been done in the southern parts of India. North India is somewhat lagging behind, and Delhi stands at 123. The numbers might have increased by 1 or 2, but I think 123 is the current number till July, August. But South India has done most of the transplants because organ donation is much better organized in South India. This is where we are, slightly more than 1,000 transplants in India so far. So a lot needs to be done. This is the number since 1994. Thank you. That's all I have to say so far.
Yeah, I think Dr. Sandeep, thank you so much for covering the advances in pre and post transplant workup and how the things are. A quick comment from Dr. Mukesh and Dr. Gokhale. Dr. Mukesh, unmute yourself.
Yeah. So, Dr. Rajeev, first I must congratulate you for this very well organized webinar and deliberations on heart failure and heart transplant. Second, we are always talking about why the numbers in North India are less and South India, they are very much ahead than us. In North India, we have still a misconception among referring physician and cardiologists that even if we refer a patient for a transplant, we will not get the heart. From where we get the heart? But I keep emphasizing it that there is a 90% chance of getting a donor heart within 3 months if the patient is listed with NOTO, registered with NOTO. And there are many times when we get a alert from NOTO about availability of an organ, but there are no recipients. Second, we have to be now more receptive for assist devices. And there are many times when the patient who might be waiting for 6 months or a year for a transplant, or they are not fit for transplant, modern assist devices can give them a very good quality of life and a very good survival, especially people who are above 65 years of age. So these are my two parting comments for today's deliberations. And
yeah, Dr. Gokhale, please, I think with your very, very vast experience, just a few words of wisdom.
I think that's a very nice presentation by Professor Sandeep. He has been excellent in starting heart failure clinic. He has been in the forefront in collecting the registry for Indian Society for Heart and Lung Transplant. That's how we got all this data. Now, one of the problems we face mainly is from the referral doctors, because see, unlike a lung transplant or a kidney transplant or a liver transplant, where people are referred yearly for evaluation, with the availability of so many medications, people keep on trying until the patient is on deathbed. And when they come to us, see, results cannot be very good like abroad because they are quite sick, like frailty index and their multi-organ system problems. We face these things. So my request to all the people is, please refer the people little early, not too late. It is not that we are going to operate these patients. It is always better that the referral cardiologist and heart failure cardiologist, they keep talking to each other, give the patient optimal treatment. And the moment you tell transplant, often the patients are not ready because most of the patients have to pay from the pocket. They need time. The family needs time. So unless we tell them when they're still in NYHA class 3, when they are able to walk around, just say that, okay, you use these medications. If it doesn't improve, not worry, there are other options available. So they get some information. So I think we need to refer the patients yearly to the heart failure cardiologist. The heart failure cardiologist should keep the primary cardiologist in the loop, talk to the family so that they take some time to get ready. Not that you get the organ immediately, not that the patient gets ready immediately. Everything takes months and months with us because people have to pay from their pocket. So my request is please refer people yearly and not too late. Yes. Not that we are going to operate, but people are in a better prepared shape for transplant. Thank you, Rajeev.
Yeah, thank you very much. I think we had a wonderful session, and there are a couple of questions in the chat box. Dr. Ajay Bhargav from Roorkee. Hello, sir. What is the incidence of hypoglycemia in the group of non-diabetics in heart failure with reduced ejection fraction? Not much different as compared to those patients who were not on DAPA-HF, on dapagliflozin. So SGLT2 do not cause hypoglycemia even if patient is non-diabetic. Dr. Sushil Chauhan from Monarica. Any role of SGLT2 inhibitors in patients of heart failure with preserved ejection fraction? There are a couple of trials in the pipeline. The results will be available soon. Deliver HF with dapagliflozin and Emperor preserved with empagliflozin are in the pipeline. We should have the results soon. Use of ARNI in patients with renal dysfunction. I think Dr. Sandeep can answer. Dr. Kher is there or has he left?
I'm here.
Yeah.
I think there is, although the ARNI use has been, the study has been done till a GFR of about 30 ml. So at the moment, there are no guidelines that you can use it below 30 ml or so. But there is a trial where HARP trial where ARNI was used with a GFR of about 20 ml or so. But this is same kind of a guideline for ACE and ARBs also. Usually ACE and ARBs have not been shown to be effective as far as protecting kidney function is concerned. But you have to know that the commonest cause of death in patients of renal failure is cardiovascular disease. They die of heart attacks, they die of heart failure, and therefore to protect their hearts, it can be used like I use ACE and ARBs in patients on dialysis as well. There are a large number of patients who are on dialysis with ACE and ARBs. So I would feel that probably ARNI would be used, and there are some certain trials which are looking at the use of ARNI below a GFR of 30 ml or so.
I think that answers the question. So with this, we come to end of this very interesting session. And I am so thankful to all the experts, panelists, and speakers who have obliged us on a very short notice of few days and taken their time to share their views. Thank you very much to all. And I would like to Vasu to say a few words before we end up. Vasu, unmute yourself.
Thank you, Dr. Rajput, for organizing such a wonderful scientific discussion, and thanks to all faculty members for their presence to make this program a little bit comprehensive. And thanks to Dr. K, Dr. Sandeep, and Dr. Mukesh, and Dr. Das, and Dr. Gokhale, and all the respective panelists for their presence. And thanks to all participants as well for making out time to make this evening little bit comprehensive in terms of understanding of heart failure management, sir. So, sir, thank you so much, and I think credit goes to Dr. Rajput for making this event very successful. Thank you so much, sir.
Thank you.
Thank you,
Thank you, Sandeep. Thank you, Mukesh.
Thank you, sir. Thank you, sir.
Thank you, Dr. K. Thank you, Dr. Das.
Thank you, sir. Thank you. Good night, sir.
Thank you. Good night.